Have you noticed any spotting or bleeding after menopause and told yourself it was probably nothing? Maybe just a little irritation from dryness, or a one-time thing that went away on its own. Today, I need you to hear this clearly. Any bleeding after menopause is never normal. Not a little, not once, not probably just stress. And the reason most women don't act on it quickly enough is not because they're careless. It's because nobody ever told them what it actually means. Here's what I'm going to share with you today. There are 5 specific types of symptoms that women over 60 dismiss every single day, that their body is using to send a very clear message. I'll walk you through what's happening inside your body when these symptoms appear, what they can signal, and the exact steps to take. Because when this particular warning sign is caught early, the outcome is genuinely excellent. But the window matters, and far too many women wait too long, not because they don't care about their health, but because they were never given the information to recognize what they were seeing. I want to tell you about a woman I'll call Ruth. Ruth is 66. She went through menopause at 54, 12 years with no periods. Then, one afternoon, she noticed a small amount of pinkish spotting in her underwear. She sat with that for a moment and then did what so many women do. She explained it away. She was embarrassed to mention it, even to her closest friend. She told herself it was probably dryness, or maybe she had overdone it at the gym, or perhaps the new lubricant she had tried was causing irritation. These explanations felt easier than the alternative thought, which she didn't want to finish. She waited 2 weeks. The spotting stopped. She felt relieved, the way you feel relieved when you think a problem has solved itself. She moved on. 4 months later, it happened again. A little more this time. She mentioned it casually to her daughter, who told her to keep an eye on it. Ruth waited another 3 weeks before calling her doctor. She felt awkward describing it on the phone. She used the words, a little bit of discharge instead of bleeding, because that felt smaller and less alarming to say out loud. Because saying bleeding meant she had to admit that something might be wrong. Her doctor, to his credit, saw her within the week. The tests that followed showed early-stage endometrial cancer. Caught early, fully treated. Ruth is doing well now. But she spent almost 6 months between that first sign and her diagnosis, and she told me that every week of that delay came from the same thing. She didn't know this symptom had a name, a meaning, and an urgency. She thought she was overreacting. She was not overreacting at all. She was underinformed. If that story touches something familiar in you, hit subscribe right now. Because this is exactly the kind of information that belongs in every woman's hands, clearly, without the shame that so often surrounds conversations about this part of the body. Let's talk about what's actually happening physiologically, because understanding your body removes fear and replaces it with clarity. After menopause, your endometrium, which is the lining of your uterus, becomes very thin and quiet. Think of it like a garden that no longer has a gardener. Without estrogen and progesterone cycling through your body each month, the lining no longer builds up and sheds the way it did during your reproductive years. A healthy postmenopausal endometrium is typically around 4 to 5 millimeters thick or less. It sits still. It doesn't bleed. So when it does bleed, something specific has disturbed that quiet, and that disturbance needs to be identified, because it can range from something completely benign and easily managed to something that requires prompt attention and won't wait politely for a convenient time. Here's the important context that most women don't have. Studies consistently show that approximately 10% of postmenopausal women who experience bleeding are found to have endometrial cancer on investigation. That means the large majority, roughly 90%, have a benign cause. Benign causes include endometrial atrophy, which is thinning that makes fragile tissue bleed under minimal pressure, endometrial polyps, which are small, usually non-cancerous growths on the uterine lining, cervical changes, or in some women, a response to hormonal medications. These are all real, common, and very treatable possibilities. But here is why that 10% matters so much, and why it should motivate you rather than frighten you. Endometrial cancer caught at stage 1 has a 5-year survival rate of approximately 95%. That is one of the most favorable outcomes of any cancer when caught early. That number drops significantly as the stage advances. The symptom that catches it early is, in almost every case, bleeding, which means the bleeding is not the disaster. The bleeding is the gift. It is your body using the only language it has to say, "Please pay attention to me right now." Now, let's go through the 5 types of symptoms that women over 60 most commonly dismiss, starting with the most important one. Symptom 1. Any vaginal bleeding after 12 consecutive months without a period. This is the definition of postmenopausal bleeding, and it is the most important symptom on this list. It does not matter how little the blood is. It does not matter if it happened once and stopped. It does not matter if it was pink and not red, or brown and not fresh. Any amount of bleeding, after 12 months of no periods, warrants a call to your doctor. Not a wait and see, not monitoring for another few weeks. A call this week. The reason this matters so much is that the uterine lining has no reason to shed after menopause unless something is causing it to. Your job is simply to report it and let a medical professional determine the cause. You are not overreacting by making the call. You are doing exactly what your body is asking you to do. Symptom 2. Pelvic pressure or a feeling of heaviness low in the abdomen. Many women over 60 experience this and attribute it to aging, bowel changes, or posture. Sometimes that's exactly what it is. But persistent pelvic pressure that is new, or that has changed in character over recent months, is worth mentioning to your doctor. The uterus sits low in the pelvis. Changes in the size or structure of the uterine lining can create sensations of pressure or fullness that don't come from the digestive system at all. If this symptom appears alongside any bleeding, even minimal, it elevates the importance of getting checked promptly. Symptom 3. Unexpected or unusual watery discharge. This is the symptom most commonly mistaken for a side effect of dryness treatments or a minor infection. Watery, thin, sometimes pinkish or blood-tinged discharge in a postmenopausal woman can indicate changes in the cervix or uterine lining. It doesn't always have a smell, and it isn't always heavy. Some women describe it as needing to wear a liner, just in case, and accept this as a normal part of aging. It isn't. A change in discharge after menopause that is persistent and unexplained deserves a conversation with your doctor. Symptom 4. Pain or discomfort during or after intercourse that is new and is accompanied by light spotting. Discomfort during intercourse is common after menopause due to tissue changes, and in most cases it's related to dryness and atrophy, which we've covered in earlier videos. But when that discomfort is accompanied by spotting afterward, or when the pain is new and located deeper in the pelvis rather than at the vaginal entrance, it should be noted and reported. The two symptoms together create a picture that is different from standard atrophy-related discomfort, and that picture deserves a closer look. Symptom 5. Prolonged fatigue combined with any of the above. On its own, fatigue in women over 60 has many explanations, but unexplained persistent fatigue occurring in the same time frame as any of the 4 symptoms above is worth flagging. The body diverts significant energy when it's managing something internally. This tiredness often doesn't respond to more sleep or rest the way ordinary fatigue does. When it appears alongside any of the other symptoms on this list, it adds important context to the overall picture. Now let's talk about what to actually do, in clear, practical steps. Step 1. Call your doctor the same week you notice any of these symptoms, specifically bleeding. When you make the call, use the word bleeding, not spotting, not discharge, not a little bit of something. The word bleeding communicates clearly what your body is doing and ensures your call is triaged appropriately. This is not about being dramatic. It is about using the accurate clinical word that gets you seen faster and taken seriously. You do not need to apologize for calling. You do not need to preface your words with, "I'm probably overreacting," but simply say, "I'm in my 60s. I've been postmenopausal for several years, and I noticed vaginal bleeding this week. I would like to be seen." That sentence is complete. It communicates everything your doctor's receptionist needs to prioritize your appointment correctly. Practice saying it out loud if it helps. It is a sentence that could genuinely change your outcome. Step 2. Understand what the evaluation typically involves. The first-line assessment for postmenopausal bleeding usually involves a transvaginal ultrasound, which measures the thickness of your endometrial lining. If the lining is thicker than expected, or if the ultrasound raises any questions, the next step is typically an endometrial biopsy, which samples the lining directly. Both of these are outpatient procedures. Neither requires hospitalization. The biopsy can cause cramping, similar to a strong period pain, that usually resolves within a few hours. Knowing this in advance removes much of the anxiety around the process. Step 3. Know the risk factors that increase the importance of vigilance. Certain factors are associated with higher risk of endometrial changes. These include obesity, because fat tissue produces estrogen independently of the ovaries and can create prolonged endometrial stimulation after menopause. Diabetes and high blood pressure are also associated with increased risk. Women who went through menopause late, after age 55, had a longer cumulative exposure to estrogen. Women who never had children, and women who have taken estrogen-only hormone therapy without progesterone. None of these factors mean you will develop endometrial cancer. They mean you have additional reason to take any symptoms seriously and get evaluated promptly. Step 4. Understand the role of lifestyle factors in supporting uterine health. From a functional medicine perspective, several lifestyle factors play a meaningful role in managing the hormonal environment that influences endometrial health. Maintaining a healthy body weight is the most well-documented modifiable risk factor because of the estrogen produced by fat tissue. A diet high in fiber and vegetables, particularly cruciferous vegetables like broccoli and cauliflower, supports the liver's ability to metabolize and clear excess estrogen. Regular physical activity is associated with lower endometrial cancer risk in multiple large studies. And managing insulin resistance, since elevated insulin levels appear to promote endometrial cell growth, makes dietary choices that support stable blood sugar consistently relevant. These are not treatments for cancer. They are the foundation of a hormonal environment that reduces the conditions under which endometrial changes are most likely to progress. Always discuss specific supplementation or dietary changes with your doctor, particularly if you're managing other conditions. Let's go back to Ruth for a moment. After her treatment, which was successful and completed within 6 months of her diagnosis, Ruth told me something that I think about often. She said, "I lost almost half a year between that first spot of pink and my diagnosis because I kept waiting for a reason to take it seriously. I kept thinking, if it gets worse, then I'll call. But it didn't get dramatically worse. It just kept being there, quietly, until someone finally put a name on what it was." She also told me what she wishes someone had said to her that first afternoon. She wishes someone had told her that the symptom itself was the reason to call, that she didn't need it to escalate first, that once was already enough. She asked me to pass that on. So consider this me passing it on to you directly. So here's what I want you to do right now. If you have noticed any spotting or unusual bleeding after menopause, and you haven't called your doctor yet, make that call this week. Not after the weekend. Not after you see if it comes back. This week. Leave a comment with one word describing how this video made you feel. Informed, relieved, concerned, whatever it is. Because reading the comments from women who took action after watching something like this is one of the most powerful things that can happen in a community like this one. And please share this video with every woman you know who is over 60. Not because you want to scare them, but because they deserve to have this information clearly, without the shame that has kept this conversation too quiet for too long. You are not overreacting by calling your doctor. You are not being dramatic. You are listening to your body and advocating for yourself, and that is exactly the right thing to do. Subscribe for more honest, practical conversations like this one. I'll see you in the next video.